Everybody, thanks for coming. My name is Kara Feldman-Hunt. I'm the program manager of UVM Integrative Health, which is a initiative. It's a joint initiative with the UVM Medical Center, the UVM College of Nursing and Health Sciences, and the UVM Lerner College of Medicine. A lot of UVMs. Glad everybody could make it. If you did not sign up ahead of time, if you could just sign in on your way out, that would be helpful. You can get CME credits or CE credits if you'd like. In order to do that, you go onto the My Credits application on the UVM website. If you just go in the search bar and Google My Credits, you'll find it, or email me and I'll help you. We have another event coming up in December 4th. We have a woman coming from Mayo. She runs the Physician Wellbeing Program. Her name is Lottie Dribby. And she's going to be talking about burnout and why it's important to healthcare systems and patients. So that should be really interesting. It's at 8 a.m. During Family Medicine Grand Rounds. So I'm going to introduce you to our speakers tonight. We actually have 3 speakers. First up is Dr. Caleb Friedman. He's an assistant professor of surgery and pharmacology at the UVM Lerner College of Medicine and attending emergency physician at the UVM Medical Center. He obtained his MD and PhD at the University of Colorado. He completed an emergency medicine residency at Boston University in 2007, after which he joined us at the University of Vermont. His lab is working to understand trauma physiology and develop novel therapeutic targets to improve outcomes for trauma patients. The National Institutes of Health and the Department of Defense Fund are funding his research. Dr. Freeman also teaches in the Department of Pharmacology. And after Dr. Freeman speaks, Shane Lynn and Bridget Conry from the Champlain Valley Dispensary will talk with us. Shane's the executive director and founder of the Champlain Valley Dispensary. It's the state's first medical marijuana dispensary. Shane designed, sourced, and managed the construction of Champlain Valley Dispensary's cultivation facility and has provided recommendations and public testimony to state regulators in Vermont for over a decade. Under his leadership, CVD was awarded a second license in 2013 and opened Southern Vermont Wellness in Brattleboro in February 2012. Did I get that right? Yeah. Kind of, sort of? Okay. And Bridget has experience managing a multi-million-dollar bakery and farmers markets both in New York City and Lenox, Mass. She's been a 15-year student of traditional systems of herbal medicine and was the owner of Elemental Herbal Apothecary, an herbal clinic and product manufacturer. Bridget is now Director of Operations at Champlain Valley Dispensary. She's responsible for the implementation of the organization's mission statement and standard operating procedures across 5 departments: processing, extraction, laboratory testing, infusion kitchen, and facilities. So I think we are all in for a good treat tonight. So take it away.
Hey, all right, thanks everyone. Can you, I'm going to try to use this microphone. Can everyone hear me okay? Great. Thanks a lot, Kara, for having us tonight. And I see some UVM students here, some faculty members. It's great to have Shane and Bridget here from the community. And happy to talk to you about some of the things that we've learned here at UVM Medical Center about CBD and cannabinoids and as medical therapeutic agents. I just want to start off with the disclosures that I've got conflicts of interest to disclose with the Phytoscience Institute, Vermont Patients Alliance, and Green State Gardener. And I should also note that we're going to talk about investigational drugs. CBD is now listed as an investigational new drug, IND, that is not currently approved by the FDA. So the things I'd like to kind of talk about today, one thing is the meta-analysis published in 2015 from the Journal of the American Medical Association. It's our highest impact journal in American medicine. And in 2015, they did a comprehensive meta-analysis providing, showing where the evidence is for therapeutic use of cannabis. And they listed 2 conditions that have what they said moderate quality evidence and 4 other conditions with lower quality evidence, but at least there is some. So those 6 conditions I wanted to talk about today. Seizure is not one of those, but there is new emerging evidence for cannabidiol and seizure management. So I'll highlight some of those new studies for you as well. Second, I want to talk about the adverse events. Like all therapeutic drugs, cannabis and CBD are not without potential side effects. So I want to make sure that you guys who are practicing medicine in the community, if you have questions from patients and families and caregivers, you should know both when is there a potential therapeutic benefit and also what are the potential adverse events. And third, I want to talk a bit about the potency and quality of medical cannabis products, specifically focusing on the CBD products that are currently available to our patients here in Vermont. And again, my background is in molecular biology. My PhD training was in molecular biology. I work in the emergency room here. And one of the things that got me interested in this whole area of cannabis medicine is looking for alternatives to opioids for chronic pain. Here in the ER downstairs, we are resuscitating people with opioid overdoses daily. And it's gotten increasingly difficult over the past decade. So I think a lot of physicians are looking for alternative therapies that can help manage chronic pain without such a risk of overdose. And so this is potentially one of those areas. I also want to highlight that UVM was the first medical school to offer cannabis education by medical school faculty. There is currently a translational science and medicine program run through the Department of Pharmacology. If anyone's interested, you can go online and sign up for a 7-week course in cannabis science and get a certificate. The course is in its 7th week this semester. Right now it's finishing up, and we have people from Ecuador, from Thailand, from around the world, pharmacists and physicians and industry people looking for quality information in this area. There's also, along with the certificate program, there's CMEs available. There's about 7.5 hours of material that you can download at your leisure if you're interested in some of the subjects that are covered. Include medical legal issues, biology and basic science, clinical practice, 3 modules focusing on different, some of these indications that have the most evidence for cannabis. Chronic pain, cancer palliative care, MS, and seizure. All right, so I'll move on to some contents here, and again, there's a lot of material we've accrued over the last few years teaching this at the med school in pharmacology. I'll give you a kind of a very tip of the iceberg overview of some of the things that I think you'll be interested in. And if there's questions during my talk, I would say please interrupt, and I'll try to answer quickly. Feel free to interrupt. I'm okay with that. I don't know for these guys. But we will not do a question-answer session until the end of the entire presentation. So, but if you do have a question during the talk, if there's something that I'm going too fast or not explaining adequately, feel free to raise a hand, and I'll try to get the answer into you. Historically, the idea of cannabis as medicine is not new, right? This is a very old idea. There's thousands of years of documented use of cannabis as a medical product. I picked this quote because we're talking about CBD today. And Sir John Russell Reynolds was the neurologist and seizure expert who was also the house physician for Queen Victoria. And he was using Indian hemp for Queen Victoria's menstrual cramps for PMS back in the 1800s. And he had a quote that I thought was interesting in our discussion here about opioids, saying, in almost all painful maladies I have found Indian hemp by far the most useful of drugs. The bane of many opiates and sedatives is this, that the relief of the moment, the hour of the day, is purchased at the expense of tomorrow's misery. In no one case to which I have administered Indian hemp have I witnessed any such results. So this idea of hemp oils or cannabis being an alternative to opioids, this is not new either. And this is published in The Lancet in 1890, so over 100 years ago. I'm not going to go into all the political reasons why we don't have more data on this. What I will do is show you the data we've got. And I want to talk about what is hemp today. So this is a hemp farm in Hardwick, Vermont from last season. We currently have hemp growing at the UVM Extension Farm with Dr. Heather Darby for research purposes. And so hemp is currently an active area of research here at the University of Vermont. Briefly, to understand what is hemp and cannabis doing to the human body. To understand what it does and what the therapeutic effects are, you need to understand a little bit about the endocannabinoid system. And this system in the body was discovered after THC was discovered and identified, and we used radioligands of analogs like THC to identify the receptors to which they bind and uncover this basic system in our nervous systems that responds to endocannabinoids, which are endogenous cannabinoids, so things that your body makes on its own. This is different from phytocannabinoids, which are those derived from plant products. And there's also synthetic cannabinoids that are made in the lab. So the endocannabinoids are made, again, by our body. There's different parts of the system are the receptors, which are predominantly in the nervous system, but also play a major role in the immune system response, inflammation. The endogenous agonists that activate these receptors are your endocannabinoids. The one that you probably have heard the most about is amantadine. And then there's agonists metabolizing enzymes and reuptake mechanisms that are important. And if you think about something like serotonin, a lot of the drugs that are used for depression are selective serotonin reuptake inhibitors. So they inhibit the reuptake of serotonin. So like all local hormones, the reuptake or the metabolism of the cannabinoids is an important feature in how the body responds to them. So where do the receptors reside? So CB1, the cannabinoid 1 receptor, is found predominantly in neurons, but it's also present in adipose tissue, so in your fat cells, in the blood vessels, in the gut, and in reproductive organs. There's one thing I'd like to highlight in the autoradiograph here shows a labeled THC analog and where it uptakes in the brain. Really interesting, the lowest densities, the darkest area are in the brainstem. Right? So the brainstem is the portion of the brain that controls your respiratory drive and your heart rate and involuntary activities of the body. The brainstem is full of opioid receptors. So when people take opioids for pain, you can shut down the brainstem and stop breathing and drop your blood pressure and die. The brainstem does not have cannabinoid receptors. So this is one of the reasons why overdose of cannabinoids does not cause lethal effects. CB2 is primarily expressed in the immune system, on the immune cells, and helps respond to inflammation. Cannabidiol is so the molecule shown here. It's very similar to delta-9 THC with the exception of that hydroxy ring. One of the benzene rings is broken open, causing a little more mobility and different binding affinities. CBD is the primary naturally occurring cannabinoid in the hemp plant. And this is different from what's considered medical marijuana or recreational marijuana. The primary intoxicating psychoactive ingredient in those plants is THC. So CBD has different effects from THC. In particular of interest is that it doesn't really activate the CB1 receptor. It's got inverse agonist properties. It can actually help reverse the psychoactive effects from THC. So it's not intoxicating. It doesn't have potential for abuse. Doesn't have any medical properties. You know, this is what we're talking about here. The evidence for medical properties from CBD is slim. There's not tons of data compared to things that we study more, like blood pressure pills, for example. But there is some evidence for CBD, much more evidence in animal models than in human trials. But I'll highlight some of the clinical data that we've got. This idea of CBD alone, without THC, so a hemp oil extract with no THC present, being used for chronic pain, insomnia, muscle relaxants, health supplements, this is relatively new. And Shane and Bridget will talk a little bit more about what they're seeing in the dispensaries. But it's an interesting phenomena. You know, in the state of Colorado, people can buy recreational marijuana full of THC, and yet there's a growing market for CBD products, even in places in the country where THC is widely available. So there's a big interest in CBD among the general population. Does it do anything? Like, does it actually work? So we're going to get into some of the weeds on this. What we do know about CBD is that not only does it activate CB2, the immune response, a little bit, and kind of block the CB1 receptor, it also has activation effects on other receptors that are not specifically cannabinoid receptors. One of those is TRPV1, transient receptor potential vanilloid type 1, that you would probably know better because it's the receptor for capsaicin in hot peppers. So this is the sensory receptor that responds to hot pepper substance, capsaicin. TRPV1 is also activated by CBD. TRPV1 is important in your pain signal pathways that let your body respond and sense a pain signal. And capsaicin, the TRPV1 agonist, is used in pain research and in pain trials sometimes. There's capsaicin creams and things. The idea is that you can stimulate TRPV1, downregulate those receptors on those neurons, and then decrease pain responses. So that's the most likely mechanism of action. There's one other mechanism, which I'm not going to show here, but which has been postulated, is that the development of chronic neuropathic pain after you have an acute injury or surgical procedure, some people develop these chronic pain conditions. And you're much more likely to develop a chronic pain condition if you get opioids, right? And part of that chronic pain involves inflammatory responses in the neurons. So one of the other hypotheses for why CBD seems to be so useful in pain is that by decreasing the inflammation response, you prevent the progression to chronic pain conditions. So that's some of the very quick overview of what we know about the physiology and pharmacology. In terms of clinical trials, things have really blown up since around 2009. Between 2006 and 2009, there was a few studies in cannabis science that came out of California, funded by their medical marijuana program. Around 2009, so now almost 8 years ago now, this company called GW Pharma in the United Kingdom began a very ambitious program to get FDA approvals for cannabis products. Now, the FDA approval process, for those of you guys who do this kind of work, as you know, it's in the multiple billions of dollars to get a drug FDA approved. The estimate's somewhere between 3 to 5 billion. Not cheap, right? And so this is why very few herbal remedies have gone through an FDA approval process, because the cost is really high. And if you can't market it, there may not be a value. GW found a way to get extracts and patent the extraction process into their products. They found a way to patent their products, and they are now actively engaged throughout the world in multi-center clinical trials using 2 products, which I'll highlight here. On the top, these purple trials shown are what they call Epidiolex, which is pure CBD. So it's a pure CBD cannabidiol extract. They're accelerating that research pretty quickly because they were able to get orphan drug status because it's a target for pediatric seizures. So these, and you guys might know the story of Charlotte Figi out in Colorado and other pediatric seizure cases. These are actual intractable pediatric epilepsy conditions caused by mutations in ion channels in the nerves that are very well understood, and unfortunately they're refractory to most anti-epileptic treatments. So these are these children with different mutations causing what we call Dravet syndrome or Lennox-Gastaut syndrome are plagued by persistent chronic seizure activity, and in many cases they do not respond to any of the anti-epileptic drugs. So because there's no treatment for these poor kids, the FDA has granted GW Pharma the ability to accelerate the research by giving orphan drug status. So this is currently in trials here in Vermont. If you have a child in Vermont with Dravet syndrome, you can refer them to Dr. Greg Holmes. He's our head of neurology here, and he's a partner for GW Pharma and in this trial. I think there's only a couple kids in the whole state that are currently in this, but it is available to certain individuals who meet the very specific criteria for the research trial. The other product, which is actually it's not orphan drug status, so they've partnered up with other groups to make this research happen, much bigger research program, is their Sativex or Sativex drug. The generic name is nabiximols. This is a 1-to-1 mixture of THC and cannabidiol. So it's THC and CBD mixed together in a 1-to-1 ratio delivered as a sublingual spray. And I'll show a couple examples of research with this product. And you can see they're already going through phase 3 trials in this. They've moved quite far along. This is currently approved by European drug companies or regulatory agencies. So in some European countries, you can currently go and buy this in a pharmacy. In the US, it still needs to go through phase 4, get to the market. It probably will get there in our lifetimes here, but I wouldn't hold my breath. And when it is available, it's going to be pretty expensive. But the reason I show this, and I think it's so important, is because of this major research effort by this British drug company, we actually, in the past 5 years, have this big volume of new data, which was not available when I went to med school or most of our physicians. This is new data that has only become available in the last few years, which gives us new insight into what are the therapeutic uses of cannabis and what are the risks, what are the adverse events. Yes, sure. Yeah, of course.
So I'm just curious, when they're testing it for type 2 diabetes, like what is the application?
Glucose control for diabetes and schizophrenia is trying to decrease psychosis. The idea is that CBD, again, these are trials that are ongoing, but there's antipsychotic effects from CBD. And it blocks, it's kind of opposite the effects of THC. So there's a theory that this might actually work for acute psychosis. Glucose control, for decreasing sugar levels, yeah. Because of the inflammatory process, because part of the development of insulin, especially type 2 diabetes, as we get older and with the obesity and hypertension, inflammation of the pancreatic beta cells is one of the drivers of the diabetes phenomena. So the idea is by decreasing the inflammation, you can prevent the elevated glucose and maintain normal insulin production. People ask me about these indications all the time, and I usually say, I don't recommend them today. You know, the jury is still out. You know, these studies are ongoing. They're only in phase 2 for some of these studies. So this is, you know, phase 1 is you just try to establish if people can take it and tolerate it. Phase 2, you start to look for therapeutic benefit. It's not till phase 3 and 4 that you get large numbers of subjects, so we can really make decisions on. So early data, but I would just stay tuned to these indications in the future. People may ask you guys as providers about those indications. At this point, there's just not a lot of hard data to stand on, but in preclinical models and other basic systems, they do seem to have some potential effect. Yeah?
Are you interchanging the terminology cannabis and CDB?
I am at this point, and I will distinguish those later on. And this is based on JAMA's language. So I'm using the American Medical Association's language. What they did in their meta-analysis and the papers that they're in that journal is they talk about CBM, cannabis-based medicine, with lower cases. The word cannabis with italics is reserved for the plant itself. So that's a scientific word for the plant. So the cannabis, uppercase italicized, is the plant. Anything extracted from the cannabis plant is cannabis-based medicine, or more simply referred to as cannabis in JAMA and the other literature. Good question, though. And in the meta-analysis, they do look at data from both, but most of the data is actually this product, Sativex. So the majority of clinical trial data that we've seen published is with the 1-to-1 THC-CBD mixture. Any other questions right now? Feel free to jump in. Okay, so I'll give you an example of one of the studies that's in the meta-analysis that was conducted by GW Pharma. So you understand kind of where this information is coming from and what's the quality of the data that we're talking about. So this study was Portney et al. was the group based in New York, and they looked at nabiximols, which again is the generic name for Sativex. This is your sublingual spray, 1-to-1 THC to CBD, and they looked specifically at cancer patients using opioids with poorly controlled pain. Can we get something else to help these folks with their pain? So a very specific target population. And the way they set up a trial like this is their study design. So you can see temporally moving across 35 days here. There's the screening and randomization period. They wanted to make sure people were not using any cannabis before they got into the study. They randomized people to different dosage of their Sativex, 1 to 4, 6 to 10, or 11 to 16 sprays per day is how they did this. At the end of treatment, they did a follow-up period over 14 days, and they measured the patient's pain responses. And they also surveyed people about their adverse events and side effects. This is your consort type of flow diagram showing the flow of patients through the study. And these sample sizes are pretty big. When we talk about this for the UVM class, we show a lot of other studies with relatively small sample sizes. The smoked cigarette, cannabis cigarette studies had often 10 or 12 people in the study in each group. Here we're talking 503 people screened and 360 randomized. So this gets to be a kind of a pretty good sample size, over 300 subjects. In the different groups, they had 91 subjects that went through the 4-spray, 10 sprays, they had 87 that made it through, and 16 sprays, they got 90 through, and for the placebo group, they had a placebo arm. And remember, a placebo effect is important. There is a placebo effect almost every medical condition, so it's important to include a placebo arm to show that there's efficacy. The placebo arm had also 91 patients. This is the type of patients they studied. Again, they show the different groups, including placebo, and how many people were in each group with each type of cancer or type of pain. And there are differences. Neuropathic pain, as clinicians here know, is probably the most difficult to treat, or mixed types of pain that are neuropathic and somatic. You can see a variety of cancer types and different classifications of their pain. And here's what they found. So the adjusted change from baseline in their pain, the placebo group had a decrease in pain of about 1 point on a 1 to 10 scale. So not a huge reduction, but again, placebos always do something. So here's your placebo effect, is about 1 point down. With 4 sprays, they have a pain reduction of almost 2 points. And this is more than we get with Motrin, or our non-steroidal anti-inflammatories. Interestingly, when they went up on the dose of the Sativex, there was no benefit, and they got more side effects. Right, so this is important, again, for the clinicians here, and as we talk about quality and potency of the products, like a lot of drugs, there's a therapeutic window. And this study was designed to determine what is that therapeutic window. As you get to higher doses, you get more adverse events, but you don't necessarily get more pain reduction. Right? So titration of the dose is an important aspect of this. In this group, their primary outcome was looking for a 30% improvement of pain. So that's 3 out of 10 points. You could see on that list they only got close to 2 points of pain reduction, not 3. So this was actually a negative trial. In this trial, despite a big sample size, a lot of money, and a lot of patients, they did not show the primary outcome effect of a positive response based on their criteria of a 30% improvement. But they did see a good signal in terms of reduction in daily pain, reduction in mean worst pain, and reduction in sleep deprivation. So again, this is an example of one of the studies that made it into the meta-analysis. So the meta-analysis reviews dozens and dozens of papers. So I want to move from that kind of example of one paper to now the systematic review of meta-analysis. This is a specific type of statistical tool that's used in medicine, and like we teach here in the med school, this is the best evidence that we can generate is from a meta-analysis, better than any individual trial. The reasons are, one is that you're getting patients pooled from multiple sites. So there may be something special about those people in Southern California that is different from Northern Vermont or in Europe. So by pooling results from multiple trials, you can kind of normalize the variability, and you also have the ability to get much more info about the adverse events because you get larger sample sizes. The other thing they do with the systematic review and meta-analysis is they grade the quality of the research trials. Was the research trial done without bias? Was it funded by the industry sponsor, and was there evidence that it was, could it potentially be tainted by industry funding? Can we trust the results? Did they use proper placebo control groups? Was the randomization process appropriate? So they actually go through each of these studies and determine the quality of each one to come up with a composite assessment that we as clinicians will use to make therapeutic decisions. So what they found is moderate quality evidence to support the use of cannabinoids for the treatment of 2 conditions, chronic pain and muscle spasm due to MS. They also found some evidence, which they considered relatively lower quality, suggesting, not really proving, but at least suggestive evidence from decent trials showing improvements in nausea and vomiting due to chemotherapy, weight gain or cachexia in HIV, sleep disorders, and Tourette syndrome. So those are 6 conditions that they were able to find some published data with randomized trials that we could actually hang our hats on and come up with an odds ratio and assessment. One thing I want to note here is that this was funded by the Swiss government, this study, and they did not include seizures. And it's not clear why, but they looked at 2 or 3 dozen conditions, but seizures was not on their list. So we have nothing here to either support or go against seizure data. So I won't show all the data here, but I'll show a little bit of it. Again, I'd encourage you to pull this paper because it's such an important one, but I'll show an example of how I would go through it. This is specifically looking at the studies that were done for pain. So of those 6 conditions, the one condition with the most data that I think as clinicians we would all agree actually this data is, I think we can have consensibility on the interpretation of this. They had 28 studies they identified that were randomized, controlled with placebos, looking at chronic pain, and these 28 studies were published in 63 different papers, and the total number of participants that were in these studies, including the placebo groups, were over 2,000. So we have 2,454 patients. So a decent sample size. And what they show here is the different, the question about, are we mixing CBD and THC here? The cannabinoid study is shown in this column here. One study with smoked THC, all of the rest are Sativex, nabiximols. All of the other quality randomized controlled trials are with CBD to THC mixtures. In 2015, they were unable to find any quality studies with CBD alone. So just to highlight that, CBD was one of the components studied here, but this data really speaks to mostly the combination of CBD with THC. The research on CBD alone versus placebo is still coming out. We don't know yet. The outcomes they looked at, you can see compared with placebo, they looked at the outcomes, generally a pain reduction scale on your numerical rating scale. How bad your pain on a scale of 1 to 10. The goal was to see a drop generally by 3 points or more. And you can see in all these cases, the result was favoring CBM, which is cannabis-based medicine, was better than placebo in all the studies except for this one. And the grade rating is how, again, the quality of those studies. So this is very carefully explained what they grade the studies on. These are mostly what they would say moderate quality clinical trials. One of them was considered low quality. But so this is the studies that they identified that were suitable for the meta-analysis statistic. And here's how they summarize the data. And this is what we're used to looking at in medicine is these odds ratios. What's the odds that a patient will get better if you give them this drug? So if you can see, the Portnoy study is listed here, which is the one I showed here, which was the negative study. And so in this case, you can see compared to placebo, it's not really better than placebo, kind of favored placebo, if anything. So this one was not a positive study in that sense. When you look at the overall compilation of all the people who took cannabinoids, all the people that took placebos, and the compilation of the results, overall, you have a 1.4 to 1 ratio. So over, and the confidence intervals are over 1. So you have a statistically meaningful and clinically relevant increase in a decrease in pain or improvement in symptoms. And again, this is more than we see with non-steroidal anti-inflammatories, less than what we see with opioids. So just to get this into perspective, as a clinician looking at this, I think most clinicians would agree that this seems to be a potential therapeutic agent, but how much of a benefit is it? It's not going to take the place of fentanyl if you come into my ER with a broken leg. You're going to get fentanyl or morphine if you have an open fracture or if you're going through surgery. But for chronic pain conditions, for low-level pain, for neuropathic pain and cancer pain, this might be a really good target. But not without risk. So this is what, again, one of the benefits of the meta-analysis method is you can pool adverse events. And what they did here was not just the adverse events from the pain studies, but also the adverse events from studying Tourette's syndrome, from HIV, from diabetes, all the other studies that were out there. They were able to pool the adverse events. And the table's too small to read there, but what that shows is a few dozen different adverse events that are associated with cannabis, and what are the odds that you will have one of those if you're taking a medical cannabis in a research trial. The odds overall were 3 to 1. So the odds of getting an adverse event are probably higher than your odds of getting pain reduction. I'd throw that out there. The good news for me, again, as an ER doc, is that the adverse events weren't anything horrible. You know, when you watch an ad on TV about all the things that can happen if you take, like, Neurontin or something, you can see liver failure, kidney failure, seizures, death. Nothing like that happened. We didn't see any death. We didn't see any fulminant liver failure or respiratory failure or hypotension. But we did see adverse events. So these are important that patients and the providers and families know that these are risks. Most, and I put them in color-coded so you can see them here, but 5 to 1 odds that you're going to have an adverse event of dizziness or disorientation. So fairly high. A 4 to 1 odds of confusion, drowsiness, or euphoria. 3 to 1 for dry mouth and somnolence, and then some other things that they saw, at least 2 to 1, like anxiety, paranoia, and hallucinations. So, and again, these are dose dependent, but this is the summary data. Yeah?
All of that data relates to a mix of THC as well.
That's correct. And we do, that's exactly right, yeah. And most of this is THC given with some CBD present. So this is about a great point, and I would hypothesize, I think we would agree, if it was pure THC with no CBD, you'd probably see more adverse events. If it was pure CBD with no THC, we just don't know. I'll show you some data from the pediatric seizure study on the pure CBD, but we don't have this wealth of thousands of patients that have taken CBD, especially adult patients, mostly kids. Any other questions about this meta-analysis? Good question. That's a good question. I mean, for people with depression, that could be your therapeutic target too. I don't know. So, question back here?
No, just 5 minutes.
Okay, great. So I'll move along. There's a couple other points I'd like to show that are I think interesting to the community here. One of them is the fact that we live in Vermont with an opioid epidemic makes us wonder what's the potential public health impacts of cannabinoids in the context of our opioid epidemic. I mean, if you think of cannabinoids themselves, they may have some adverse events and addiction potential. It's well known. But how does it interact with the current scenario that we have in New England with an opioid epidemic? So there's some data emerging here that there may be a lower level of opioid overdoses in states that have legalized marijuana. Again, this is association data. You can't say it's causal, but this is this was published in Annals of JAMA Internal Medicine in 2014. Another study, this was in the Journal of Pain in 2016. I'll just do some quick highlights of some papers I think are very interesting here. 2016, Journal of Pain, they did an online survey, and I think this is in Ann Arbor, Michigan, of 184 patients who were using cannabis as medicine and saw a 65% reduction in opioid use. So that's a big signal. Again, this is a survey. This is not placebo-controlled. This is not a clinical trial. It doesn't meet the level of evidence that we talked about in the meta-analysis, but it's an interesting observation, and I think we're seeing this in Vermont as well. This is that same paper here from 2016. Chronic patients may successfully substitute cannabis for opioids and other drugs used for chronic pain. I'll show a couple slides on the CBD, and then I want to wrap up and just show some data on CBD in Vermont. There's a new paper that came out just yesterday. I had to add that to the talk. So I'll leave 1 minute at the end for that. But so this is the pediatric seizure study. Davinsky in New York published this in a good journal. It was a Lancet Neurology just last year, looking at kids, 214 subjects, kids with these intractable seizures. And I won't go through the whole study trial. But let me bump up to the results. They showed efficacy, the mean reduction in monthly motor seizures of 36.5%. So a big drop in seizures for kids who responded to no other drugs. So this is interesting. In terms of safety and adverse events, similar to what we saw with marijuana, somnolence, decreased appetite, maybe with dry mouth. They had diarrhea in this group, and they reported some seizures, although these are kids who have seizures every day anyways. So whether the seizure was caused by the drug or not, hard to tell. But again, nothing terrible here. We didn't see serious adverse events that were related to the drug, although one of the subjects did die. So I just want to wrap up here with a couple slides about CBD in Vermont. So how do you get CBD? I want to try it, right? I'm sure your patients have asked, or they will if they haven't yet. It was available on Amazon and still is, but there's some, the FDA sent out warning letters, and I won't go into all the politics here, but this is really interesting that because of GW Pharma getting IND approval for CBD, it's no longer considered a dietary supplement. So as soon as it got IND status, the FDA went after all the people selling it as a dietary supplement. So there's some challenges here with actually selling these products. In Vermont, there's a bunch of products now available. Healthy Living, Whole Foods, the Siri shops downtown. There's places to buy CBD across the state now, and you can order it on the internet. We did a trial here looking at do the products actually have CBD in it, given that there's very little regulation in this industry. And for this study, this is something we just did here in Vermont. We took 24 samples, some on the internet, some at stores, and did supercritical chromatography to determine what the potency was. Using standard methods, you can see our curves here, very nicely calibrated instruments. What we saw of 28 stores that we studied, 22 carried CBD and 6 didn't. 24 products were purchased from 11 stores. Of those 24, 7 were capsules, 11 were tinctures, 3 cartridges, and 3 concentrates. Good news, all 24 had CBD in it. I was surprised. I expected some of them were going to be just rice extract or just, just something, and they're just made, because these are very expensive products, and they're not covered by insurance. People are paying out of pocket big dollars for these. Do they even contain the drug? Surprisingly, they all did. One thing to note, some of the drug was not decarboxylated, so it was CBDA, so it's not going to be as bioavailable as a CBD form. So it requires heating or an extraction process to decarboxylate it. So whether all that CBD is bioavailable, it was not. There was also some THC. We found one product that had THC levels of 0.8%, so above the legal definition of hemp. So there may be some THC in these products, but it wasn't like really high. It was relatively small. The challenge with it is the accuracy of the labeling did not meet our standard definitions in pharmacology of being within 10% of the label. You'd like to see that if it says it's 20 milligrams, it's between 18 and 22, within 10%. And about half of them were under or over labeled. Only 50% were labeled within that 10% range. And I'll move very fast in the last minute here just to say that yesterday, JAMA published the same trial. They kind of stole our study here, but nonetheless, I'm not worried about it. I think it's just important data to know. So, labeling accuracy of CBD products sold online, and they sampled 84 products online, and what they saw, accurate under and over labeling, they said 1/3 were labeled accurately. So of the online CBD products, only about 1/3 of them had the potency that was advertised. And THC was present in levels up to 6 milligrams per ml. So that's 10 milligrams per ml is 1%. So this is like 0.6%. And we found like 0.8%. So very similar to what we found in our trial in Vermont. The point being that this is a very a therapeutic agent with a lot of potential benefit, but the source of the drug has to be carefully considered. And I'll wrap up here, but there's a wide range of CBD products out there with very different concentrations. So we don't even know what is the right dose. The kids with seizures were using like 200 milligrams a day, massive doses. Many of these products are 5 or 10 milligrams. Is it enough to have an effect? Some are underlabeled, some are overlabeled. The overlabeling is similar to what was previously found by the FDA when they sent warning letters to companies. And the risk of overlabeling is that someone thinks they're going to get a benefit, but they're really not getting the drug that they're paying for. Underlabeling, in their report, they said really less concerning because CBD is not an abuse liability. It doesn't have serious adverse consequences. So if they underlabel it and you actually get more than you think you are, it's not really a serious risk. But what if THC is in there? And you're talking about kids. So if you got 0.6 or 1% THC in the product, that may be a risk. So they're pushing, as I think we all are in the industry, is that we need to have really good regulatory guidance to make sure these products can be consistent and high quality. So my learning objectives again, and a pitch for our online class. If you want to learn more about this, there's all these modules available for download in more detail. So I'll let you guys jump in. Thanks.
Did you want to wear that? One of you guys. Come back. Let's make sure this is on. Yeah, okay.
Hello.
You guys are good to go.
Is that one on? Hello?
Maybe not. Sorry.
That's
Getting
all
a little
right.
intimate
Hello?
there.
Hello? Hello?
Yeah.
Great. Hello, everybody. My name's Shane Lynn. I'm the Executive Director of Champlain Valley Dispensary and Southern Vermont Wellness down in Brattleboro. That was a great presentation and a lot more scientific than we're going to talk about. We're going to talk about kind of more the real world of what's happening here in Vermont with CBD. This is Bridget Conry. She's the Operations Director at our dispensary. We started learning about CBD basically probably about 4 or 5 years ago when we got a medical marijuana license to grow and cultivate and extract cannabis for people. And we started to hear about CBD working with children that had epilepsy. And it started to kind of progress from there over the years. And at this point, it's really kind of taken on its own market, if you're talking about it that way, and its own symptom relief benefits. Let's go to the next slide. Maybe not. There we go. Disclosures. Bridget and I are going to do a few slides. I'll do a few slides, and then Bridget's going to jump in and do a few other slides, and we're going to kind of go back and forth that way. What is CBD? CBD is cannabidiol. It's one of the many chemical components in the cannabis plant. There are, I don't know, I think roughly 84 compounds at this point that have been researched in the cannabis plant. There were some questions there regarding cannabis and hemp. The best way to think about it, at least for me, it has been to think about it like an apple tree. And that you can have a Macintosh apple tree, and then you can have a Honeycrisp apple tree. And they're both apple trees, but they produce different types of apples. The cannabis plant is similar to that. You can have a cannabis plant that's grown for THC and has high amounts of THC, or you can grow a cannabis hemp plant, basically, that's grown for CBD and has high amounts of CBD and lower amounts of THC. It's non-intoxicating CBD. We used to say it was non-psychoactive, and over the past year we've changed that to non-intoxicating, realizing that people like with anxiety, CBD can help people, and therefore it is psychoactive, but it's not intoxicating. Obviously, it holds many therapeutic properties. It works synergistically with THC, and what we found is that you want to have certain amounts of THC and certain amounts of CBD. And it was discussed earlier about having a 1-to-1 ratio, basically. We grow plants that can have different ratios. They can have, 10% THC and 5% CBD, or the opposite even. And then you can go to the next level and start extracting the oil from the plant and getting this oil and then formulating your own medications in a tincture or an edible or a capsule. And so you can have real control over that formula. We don't have a lot of knowledge at this point of what are the best ratios, and a lot of the things we hear are just from patients coming into the dispensary or our store that sells CBD and hearing what works for them. And it's really a little bit of trial and error and experience for the person to get used to what is the right level of ratios for them. Currently, CBD is still a Schedule I drug here in America. And so there is some confusion around, well, if it's Schedule I, how is it allowed to be sold? And it's the same for cannabis. Cannabis is still Schedule I, and how is it allowed to be sold? In Vermont, cannabis is sold because we have a medical marijuana program that allows us to sell it. With CBD, Vermont passed a hemp law back in 2013, which allowed Vermonters to grow hemp. So you can, if you're in Vermont, you can go to the ag department, and for $25, you can get a license to grow hemp. And that allows you to go ahead and grow that plant and then extract the CBD from that plant. And so there's some, obviously some tensions between state and federal laws at this point. With medical marijuana, you have to have a card, you have to go through qualifying conditions, you have to apply at the state level to get an ID card to purchase cannabis or THC products. With CBD products, you don't need that. You can just go into a store and purchase those products. We've gone over some of these conditions. Obviously, that list is a lot longer, but this is just some of the experiences that we have with people coming in to our dispensary or our store, and some of the things that they're wondering if it will help their symptoms. And so, again, back to there's a lot of trial and error here in finding out if it does work for people. Calvin mentioned CB1 and CB2 receptors. I just wanted to make it kind of give the visual of where those are in the body, and they're obviously in the most important areas in our body. And those receptors are what CBD and THC are binding to, and I think this is something that as the field develops and research develops, we're going to have a much better understanding of what's occurring at those receptor sites. But again, back to where these are located, central nervous system, lungs, muscles, spleen, immune system, just really fundamental key parts of our body that these things bind to, which is super important, obviously. I'm going to let Bridget jump in.
So I just wanted to state again about access to and why people are coming to the different outlets to get cannabinoid products. People do have to register with the Vermont Marijuana Program to be a patient, to come into the dispensary to buy CBD products that are derived from cannabis. Products that are derived from hemp that are less than 0.3% THC can be bought online and in a variety of places around the state. It is called the Medical Marijuana Registry, but we are not health professionals. And so it's a very interesting position to be in, to be selling products that are being used for medical use, but we're not allowed at the dispensaries to talk about how much somebody should take or which product they should take and what ratio. Some people come in and they want us to even help with diagnosis and things like that. That is not our place. We're there to talk about the products that are available at our dispensaries, how they're made. And one of the nice things about the medical program in Vermont is that we're vertically integrated, which means that we control production from start to finish. We're growing it, we're extracting it, we're lab testing it, we're creating the products. So we know everything that's happened to them along the way. We can tell you, I don't think any of the facilities in the state of Vermont are using toxic pesticides, which are a huge problem in other states. So people really have to be careful about knowing whether there are residual, like neurotoxins and things in their products because they've had solvents that are in the products, yes.
So if you say you don't think anybody is, that doesn't mean that it's not allowed?
That's a good question.
Yeah, that's a good question. And so right now there is no regulation in the state of Vermont by the DPS, who are our regulators, the Department of Public Safety. It's the only state that is the case. In other states, it's usually the Department of Health or Commerce. And so there's no regulation for what we can put on the plant. So we're self-regulating, and thankfully in Vermont we've got good actors, and we're all going for that organic. We don't have organic certification, but we're using organic methods and sustainable methods, so we can tell you what we've put on the product, and it's all non-toxic. All of our cultivators have gone through the Department of Agriculture's program for pesticide application and understanding what's safe and what's not. So we can have those conversations with you.
So you're not certified just because you've done it 7 years yet? I mean,
There is no certification program for cannabis because it's federally illegal. They're working on it. So the Department of Agriculture, as we move forward every year with the medical cannabis program anyways, more regulation comes, and we welcome that. We want more people coming and looking at what we are doing so that we have that outside certification. It gives customers, the public, our patients, that confidence that we're doing things the right way. We want people to come in and look at our kitchen, look at what we're doing in the garden. And so the Department of Agriculture is getting more and more involved. And so they are working now with us to develop lab standards for potency. Right now, we're only required to do potency on infused products. When we first started, we didn't have to have any lab testing. And so it's all coming. And eventually they will add regulation for pesticide application and other adulterants, like heavy metals and things like that. So that's all coming our way. Getting back to some of the medical properties of cannabinoids, as Kalev was stating earlier, there's not a lot of research to stand on certain things, and our patients, our customers are coming to us for a whole variety of reasons that there is a lot of anecdotal evidence for. And so all of these. A lot of them, it's nausea, it's pain relief, analgesics not on there, but I think that the latest data from the Department of Public Safety, which does give us information on a regular basis about what qualifying conditions people are getting on the registry for, chronic pain, even though it was just added this past year, is what most people are coming for. And it is for symptom relief. It's not a curative program. It actually says in the definition of the program it's for symptom relief. But pain is like 72% of the people who are coming into the medical cannabis program are looking to deal with pain. And a lot of times it's cancer related. So again, these are things that people are coming to us for, and some of these are starting to be cited in journals such as this. As Kala was saying, there's relative safety in the use of cannabinoids because it doesn't interfere or interact with the brainstem, as he was saying. So, we like to say to people that you might feel like you're dying sometimes if you overdose on a cannabis, but you're not going to. It will pass, that paranoia or that anxiety that can come with choosing the wrong product. With CBD in particular, you don't really have to worry about that because for most people it is non-intoxicating. So even though the federal government schedules a Schedule I drug that has no medicinal effect and can actually be harmful to humans, other agencies in the federal government are coming out and saying, actually, no, there are no signs of toxicity or serious side effects have been observed following chronic administration of cannabidiol to healthy volunteers, even in acute doses of 700 milligrams a day, which is a lot. So CBD is not toxic, no lethal overdoses. These two bullets right here, I think the most important thing to take away from here is that you need to check with your healthcare provider about drug interaction. So even though it's generally regarded as safe, we don't know how it interacts with drugs. And your doctor really needs to be involved, and that's what we advocate for when you come into the dispensary program. Your doctor really needs to be part of this conversation. And I'm happy to say that since we started this 5 years ago, a lot more doctors are proactively getting involved.
That's what I was going to ask. You said a lot of people come to your dispensary wanting you to help them with the dose and conditions and all that. Who can help them decide how much to take? Is it your doctor? And well-versed in
Primarily, the person themselves, the patient themselves has to kind of go through that journey of experiencing with the different products. And we give them general guidelines on onset of effect, duration of effect for each of the different categories of product. Things are offered in small packages, so you don't need to spend a lot of money to figure out which products are best for you. And as we'll see in some later slides, it really is starting with the lowest dose possible and working up from there and paying attention, keeping a journal, understanding how each product works for you, and hopefully your doctor's helping you with that. And our job is to hey, you try certain products, you come back and say, oh, this one didn't work, this one worked really well, and we can kind of go from there with generalities about how these products tend to work for people, knowing that they could do the exact opposite for a certain individual, because they all are different for individuals. Yeah.
I prescribe mostly psychotropic drugs, so I'm really interested in this interaction and the activation of the cytokine.
Yeah, I'm not going to be able to talk to you about that. I put that up there as a,
What's a sufficient dose to deactivate?
yes.
That's would be a question I would ask.
Yes, and this was just put up there as an example to say that, hey, it is known in CBD, and I think that the ADA, we have the source for that, that it does interact with this enzyme that does metabolize drugs. And so you'll see that sometimes the research will show that because it's slowing down the metabolization of a drug that you're taking, that it might actually increase the effect, have it work longer, or you don't need as much, but it could actually do the exact opposite too. And it depends on if it's a pure CBD or a CBD that's mixed with THC, or if it's a whole plant application. And so we really don't know, but they're starting to do these studies where they're looking at this, but we definitely can't go in those conversations.
THC and CBD go through study from P450. This is a theoretical risk that's been there's very little documented case. There's very few documented cases of individual humans that have had problems like this. But it's a theoretical risk that I think we should discuss with people. But yeah, very little documented data to actually say what dose will
cause a change in your drug levels.
Yeah.
Theoretically, it's possible.
These were just citing some studies, more and more as institutions are allowed to study, and I know that just happened this year too, where it used to just be one place in the United States that was allowed to study cannabis and cannabinoids, but now it's being opened up and you can apply for licenses to study. So we're very excited about that, but these were just saying that for chronic pain, reducing spasticity, starting to see substantial evidence that patients who were treated with cannabinoids were more likely to experience a significant reduction in chronic pain symptoms. So, yeah, more. Oh,
That's me. Yep, I'm back up. Back to the study that Khalif referenced earlier, and we actually did a study last year that was a survey that we gave to our patients, and it was also done in Maine as well. And I think we had a group of roughly 300 Vermonters that participated in it. We did see a decrease in them using opioids when they were also using cannabis. And I think with currently, in Vermont, with the opioid crisis going on, we're just looking to cannabis as a potential alternative to help people get off those medications. And how can that work here in Vermont? And looking at the access to cannabis, you have to go through the registry. You have to go to your doctor, you get an ID, you have to have a qualifying condition. Drug addiction is not a qualifying condition. Chronic pain is a qualifying condition. And we're starting to wonder, hey, does CBD as well help people with addiction problems? And I think one of the biggest things out of all these bullet points that are probably most important is the CBD can alleviate the anxiety that leads to drug craving. And if CBD can really do that for people, can really help people and not having that craving, and that they can go a day without having that craving and then potentially go for a month without it, that can be really powerful and life-changing for people that are facing these issues every day. And we'd like to, be advocates of an open system for people to be able to access this and try something that is an alternative. And what we believe and see each day is really genuine. We've got roughly 3,200 Vermonters that are coming to the dispensaries. I think there are about 5,500 total in the state at this point that are, receiving symptom relief from a plant, from the cannabis plant. And it's been stereotyped for a lot of years at this point. And I think the science is slowly catching up to showing that it does have a benefit for people.
One thing that I'd like to add here, and Khalif referenced it earlier, is that this is an out-of-pocket expense, and it can be very expensive because it's federally legal, insurance won't cover it. So one of the issues that we're running into with replacement, and where doctors will call us, is that, listen, I'm having a really successful case here where my patient is able to reduce their opiates because of their cannabis use, but they can't afford it. And so they have to go back to the opiates because it's covered by insurance, and they can't afford to be paying out of pocket for something that works, which is heartbreaking. And so that's where we need to keep moving the research forward to start changing minds on that level, that it should be paid for.
And I guess the other point on this too is the bullet points. These bullet points were distributed. It was recently. It was about 2 weeks ago by the Congressman Blumenauer, and he put this out. And to see that there are Congress people out there that are standing behind this and pushing for it, I think is a really hopeful sign. For this, Khalif, again, we're kind of touching on same points because these are the touch points that we have in our industry at this point. And it's back to the mortality rates, the decrease of about 25%, and that was in JAMA, which is a very significant number. And again, fewer prescriptions for pain pills, hospitalization rates and dependence and abuse dropped on average of 23% after marijuana was permitted for medical purposes. And so I think back to Vermont's medical marijuana program, the dispensary program itself has been around for about 4.5 years. And so at this point, another 3 or 4 years, I think we'll start to see some data come out of that and to see what is occurring in the population in Vermont, which is obviously really important that we have real data to point at. Back to the addiction problem that we're having in the state and in the country, and 52,000 people dying of overdoses. That's the same number of people that died in Vietnam almost. And so it's really a crisis. And how do we approach this crisis? And we would hope that there's, back to CBD and THC, the cannabis plant being a potential alternative for people. And it's already been mentioned, but the U.S. DEA fact sheet for marijuana reports no deaths from marijuana. And again, I think there's very few drugs out there that you can point to like that. And back to there are side effects to using cannabis, of course, and it's not going to be helpful for everyone. But how do we at least make it an option for people to try? I would say in over-consuming marijuana, in the sense that there's no lethal dose from consuming too much of it. Of course, people make bad decisions when they are using it, potentially. The interaction part is, yeah.
I don't know.
Yeah.
Yeah, in rats, to get a rodent model to die from THC, the dose would be like more than the body weight of the rat.
Yeah.
There are a number of cases where people have taken marijuana and had acute psychotic events. In fact, there was one just last spring where someone had too much marijuana. He thought God told him to jump out of a fourth-floor story window with his son clutched to his chest. Miraculously, he survived. But there was another case in Colorado where a dad ate a cookie and ended up killing his wife within a few hours. I don't understand how you can possibly say the marijuana never causes anyone to die. If you use marijuana, you're 7 times more likely to commit suicide, major depression. High dose, 15% THC marijuana every day increases your rate of psychosis 6 times. This is unbelievable. And the interactions, there are documented cases of people who have transplant cases, they're on immunosuppressants. The immunosuppressants don't work. You risk losing your kidney. I'm speechless.
I think that's a valid point. Thanks for bringing it up. I think the literature, though, when you look at cannabis compared to other both drugs and recreational products out there, there's a lethality index as to what the typical dose that somebody would take and what level would cause toxicity. And things that are much more lethal would be caffeine, tobacco, alcohol, cocaine, ecstasy. I mean, they're orders of magnitude more risky than this drug. Not to say it's without risk, but again, compared to things that are illegal in the United States today, the safety profile is much better.
No one ever smoked a cigarette and stood up and fell down dead. But people have eaten THC products, picked up and thought God told them to kill his wife. I don't know how much clearer that can be.
We also had thousands of patients that took it in medical trials that did not report those effects. So good point, but not consistent with the data.
Yeah, and I would just say that it's really important for your doctor to be involved with your use of cannabis, to try to help prevent those things. So products. There are so many out there right now, especially in the hemp market, that anybody can buy right now, CBD products. And from our experience, I think that Vermont is a much more educated market because we have a medical marijuana program that you can get CBD products in, and we have hemp that's legal to grow. So there's a lot of hemp growing. There's a lot of people who are making their own products at home, too, with hemp. And so there's generally 4 different ways that you can consume it. I think that the CBD products are much different than the cannabis products. Most people aren't smoking CBD products. They might be vaporizing it, but it's different. It's not a preferred method. for symptom relief to be generally smoking. But for inhalation, there's vaporizing. That is the quickest onset of effect generally for people. Sublingual tinctures is another quick onset for most people with a little bit longer duration of effect. You can see tinctures, infused oils, oral sprays. A lot of people are choosing topical products or transdermal. There are transdermal patches available that people use for long-term windows of effect. And then the edibles, the lozenges, beverages, oils, gel cap. They're all out there right now. And one of the things that we say in our retail locations is that you really need to start low, the smallest dose possible, and I think that the sublingual ones are some of the best places to start because you can go drop by drop and you can understand what 1 or 2 milligrams of CBD or THC does to you. You always want to try one product at a time. You want to wait for a long time after you try it. We recommend that you try one product only for a few days before you start another one. And right now, I think that because there's this rush of hemp products that are coming to the market, whether they're made in other states that have legal programs, or there's a lot of CBD products that are made in Europe and that are imported here. People are excited to try them. You know, they're excited to get off pharmaceuticals, and one of the things that we hear a lot from people in the medical cannabis program is that people are starting to feel like they have control again over their lives, that they're not dependent on pharmaceuticals so much. But one of the risks is that there's so many options, and even though options are good and every person finds the own method of consumption that works for them, there's the risk of consuming too much. And again, with CBD, we don't know what that might be. One of the things that's better about it is that you generally won't have an intoxicating effect, so you can get symptom relief without that feeling. But I think a lot of people are thinking that more is better. And we're really advocating for the opposite, advocating for microdosing, trying to get people to actually consume less to get the effect that they wanted. And so I think generally that's better for your health, but it's also, in the case we talked about, it's better for your wallet too, because these products are expensive. So trying to get people to consume less to get the intended effect is really important. So our products, all the products available at VPA, they all are lab tested, and that is really important, that when you're choosing a product that you know that it is, to ask for lab results on them. We do have our own in-house laboratory where we test for potency on all of our products. And we're in the process of, in our stores, if we are taking on any product from outside that's made from someone else, we're testing that product ahead of time to make sure that it does meet what they've said on their label. And again, dosing, this is a big question when people come in. They want to be told exactly what to take. They're used to going to their doctor, and their doctor's saying, take one of these 3 times a day, or 5 drops 3 times a day. We can't do that. It is a personal journey, and hopefully your doctor is helping you. We talk to other patients and say, hey, if your doctor has questions that you can't answer based on what we've told you here in the initial consultations, please have them call us, and we're happy to have that conversation to talk about the products that are available. But it is personalized medicine at this point. No single ratio of product is right for everybody. And over time, people choose different products too. A product that might work for a certain amount of time doesn't anymore. People generate tolerances to cannabinoids, and so you need to change your products in order to keep that symptom relief that you're experiencing sometimes. So experimentation is the best method. Get to know your products, as I've already talked about. Administer consistent, measurable doses. And then excessive amounts could be less effective than a moderate dose. So again, go low and go slow.
Again, just touching on points of CBD and THC and where it started, and or at least where a lot of the media attention came from, and it was from Charlotte Figge, who was a child that was suffering from seizures, and she started to use CBD with low amounts of THC, and it was a certain plant that they were growing. It was a hemp plant that they ended up naming Charlotte's Web. That was on CNN roughly back in 2013, 2015. A few years ago, and that really started this knowledge or trend towards using CBD for that case, and then trying it for other things. And also, Khalif mentioned GW Pharmaceuticals. You know that there are some very prestigious companies out there researching this, and GW is in England. They grow their own cannabis plants, basically. They do the whole process in-house at their company. And they've got a trial going, and it's down, you said here, people can join here in Vermont. I know they just released some results from the trials down in Boston recently even. So this is just the history of cannabinoids and how long they've actually been in, been with us, with human beings, and it goes back a long time. And Khalif had mentioned the Lancet, I think, story. Yep, right there, 1889. California was the first state in 1996 to actually create a medical marijuana program. And then Vermont started this program in 2014, which just allowed people, Vermonters, to grow cannabis and not be arrested for it. This dispensary program started in 2013. So, and that's just the kind of the timeline of how long cannabis has been around with us. That's it.
Why are the CBD products so expensive? Is it like extracting? I mean, why is the price so high, and how do you? I mean, if you want to talk about it seriously as a replacement for opioids,
Yeah.
I mean, is there another strategy besides saying let's wait until insurance companies come?
I think the reason the prices are high at this point is, hey, if we're importing them from Europe, there's part of that. But here in Vermont, this is going to be the first. There were 90 farmers that grew CBD this year, or hemp products this year in Vermont, and we're going to start extracting in-house here in Vermont. And I think that's going to help lower the pricing. So I think you'll start to see the industry mature. So I think the pricing will come down at that point. The extraction process is lengthy, and the equipment, the infrastructure that you need to have is really considerable. And we're talking millions of dollars to do a large scale. So, and right now we're just kind of on that smaller scale of economy. And as it grows, I think the pricing will come down.
I think the other interesting thing is the state of Vermont and a lot of other states spend millions of dollars giving people Suboxone, or supporting drug companies that continue to keep people on long-term opioids with the idea that they're going to be on it for life. What if the state would do a trial for CBD? Is that feasible in Vermont? It's up to your legislators. I don't know. It's not easy to do in the medical center, but if it was state funding, I think doctors would figure out a way to do it.
Yeah. CBN is basically THC that degrades over time, and it usually adds to more sleepiness, drowsiness. As to the anti-inflammatory, I'm not sure. This is back to this industry and how new everything is, and back to the number of cannabinoids. So like right now, currently, we test for 9 different cannabinoids. And there are roughly 84 of them that we know about, and potentially hundreds more in the plant. And one thing that we do know, though, is that the synthetic form of THC does work for some people, but other people it doesn't, and then yet they'll try THC from a cannabis plant and they'll have symptom relief. And what we kind of summarize from that is that there's an entourage effect. We call it the entourage effect, basically, that it's the combination of the terpenes and the cannabinoids that are all in this whole plant that's helping people. And that when you just have one single compound, it's not as necessarily as helpful for somebody.
Understand kind of how regulated and how wild west the situation is right now. So, a customer of yours, someone wants to come to the dispensary, they have to have a prescription for it. Is that right? Some medical person.
Yeah, well, so I would say, yeah, right now for so cannabis, there's no prescription for cannabis. What it is a very nope. It's a basically if I have a condition, I go to my doctor. The state of Vermont has a list of qualifying conditions. You talk to your doctor. I'd like to use cannabis. Do you have one of these qualifying conditions? Do you have a 3-month patient-doctor relationship? And if you do have that with the doctor, they can sign off on the form, but it's not a prescription. And on the CBD front, it's the Wild West right now.
Okay, so back to the semi-regulated territory.
Yeah.
A doctor has to, so you have to have a 3-month relationship, you have to have a qualifying condition. Somebody, a doc has to sign off on your access to it. Do you ever have to check in with that doctor again? You were saying earlier, Bridget, that you tell people we'll wait if the doctors are in touch with us, but they don't have to be.
They don't. So they get a card for 1 year. And so we definitely hear from healthcare professionals that, hey, I'm nervous, I give this to somebody. I don't want them to abuse it. There are limits on how much they can buy of THC products. And the other thing we hear is that the doctors would like, hey, I want my patient to use the CBD products, not the THC. Well, they can't control that in the dispensary program, in the medical marijuana program. So this is where you're starting to see the CBD market separate from the cannabis market and become its own market because you don't need an ID card for it. And people can go into a store and just buy CBD products directly. Yeah.
So how protected is the patient, the person that's coming to you? Let's say something does go awry. From something sort of gently awry, like that could be really good.
That part's hard after it's been consumed. I mean, this is back to the normal or standard, hey, you've come in, you've purchased something. And that's where Bridget had mentioned having small packages. We have kind of sample sizes for people to try things so they're not buying large amounts of it to find out that that didn't work or they didn't like it or they didn't have the desired effect. And so coming in, it really is a process of, we're going to get into a bigger topic of strains and indica versus sativa. They're different kinds of plants. There's a lot of things, and it's a little overwhelming for new patients, candidly, the amount of information that has to be absorbed to
Make choices.
Yeah, to make informed choices. And that's our hope back to being here at UVM Health Center in the sense that we know there's not enough research out there, but we're hoping in the medical schools that people are asking questions about it and that it's being taught and at least then being said, well, this is where our knowledge ends, right here. And here are all these other questions that we need to be answering, and we're hoping people, in the medical community will start to pick those up and say, all right, how do we research those? Because we would love to have answers to those things. Again, because it works for some people and then it doesn't work for other people. And we don't have a definitive answer of why that is.
And more, where people who are coming into the registry are people who have never used cannabis before. And they're coming because nothing else has worked up until this point. They've tried everything else with their doctor to try to reduce their symptoms. And they come to us, and maybe they find something that does, but sometimes they don't.
They come to you imagining that you're an expert.
Well, what we're an expert in is cultivation of the plant, extraction, the lab testing, the other products that we make. And that's where there's really a line for us and wanting, this is again why we're here is to outreach the healthcare community to that conversation. We would love to see that conversation happening with the patients or that phone call coming into us saying, hey, my patient's, down there and what products, this is what I know or don't know. And what we end up doing, and this is why Ada's name is up here, is that she's our outreach coordinator. And that Ada's happy to come talk to doctors and healthcare professionals and come to the office and set up a meeting and say, all right, here are the products we offer, here's how the program works, just so we can educate people.
Janet brings up a good point about the Wild West side.
Yeah.
The reason why I'm here tonight is I'm a massage therapist, and I have clients who've asked me if I would consider treating them with CBD oil.
Yep.
I have therapists in the town that I work with that already advertise that they're doing that.
Yep.
And I said, well, I need to know more. But then I had a client today who said, well, if you're applying you as the practitioner who does IPDs.
Yep.
So, I don't know, it just brings up so many different questions.
It does. I totally agree.
I would be cautious that the transdermal application is going to get systemic absorption. So people who think they're going to apply a CBD or a THC cream to their knee and get it into the joints, it's really just going into the skin and getting into the bloodstream. And you're going to get brain effects. So you as a practitioner, if you get it on your hands, you will get CBD into your bloodstream.
If it's transdermal, though. I mean, if it's in a base of like olive oil things, it's not going to. A little bit, yeah.
The penetration is increased if you have.
We haven't gone into acids, though.
Yeah.
This is so there's the acid form of CBD versus just a CBD form, and so it really depends what's that product's being made with.
Wear gloves.
Yeah, well, and this is the part that is the Wild West, and I think you're going to start to see more regulations for CBD. And I would say that Vermont made a real effort when the medical marijuana program came about to not be the Wild West with cannabis, and they set up the dispensary program with roughly about 180 pages of rules and regulations that we follow. And right now, CBD is kind of the sister to THC and is kind of just hanging on, and people are doing what they want with it. And so there does need to be some consumer education, and then there needs to be some regulation. And I think the Ag Department is really looking at this, because buying a license to grow hemp for $25, and then you produce this plant and these products, who's saying how much is in there, who's saying it does this, and who's protecting the customer. On a large scale. On a large scale. There's different methods of extraction. So you could extract just with like olive oil, let something seep, and Bridget's an expert in this, and so I shouldn't.
I mean, if you're doing it at home, you just don't, unless you're bringing it to a lab to get it tested, you don't know what the potency is of it. And so I don't want to discourage anybody from doing things at home. I mean, I'm an herbalist. That's plant-based medicine started in the home, and you can create products at home, but you're not going to be able to make judgments about how much you should use because you have no idea what's in it. It's in there, but you don't know how much.
And the $1 million thing is just the equipment that fit in half of this room, basically, to do hundreds of pounds a day of the extraction. And I think there are, roughly 500 acres of cannabis being grown this year in Vermont. That's thousands of pounds. How is that being extracted? And this isn't there's machines out there to do it by 8 pounds. But if you've got 1,000 pounds, well, okay, I can only do 8 pounds a day. That it's going to take you all year to do that. So those are some of the bottlenecks that Vermonters are going to face in this.
I just wanted to say, up in Franklin County, we treat a whole lot of patients with opiate dependency, and not surprisingly, a lot of patients get that way starting very young in their life because of pain. They become dependent on opiates.
Yeah.
And not surprisingly, you also see a lot of patients on medication-assisted therapy for opiate dependency wondering about marijuana. And the use of marijuana, at least in my community of prescribers, is pretty split about whether or not that's okay.
Yeah, I understand that.
That, maybe if they're using this psychoactive medication, usually it's, I guess, cannabis on, off the street, it's distracting them from their recovery, which is really hard. It requires a lot of focus. And then the other downside that if they're buying it off the street, are they potentially getting into an illegal interaction where they can potentially encounter triggers that would put them at risk for relapse? Now, where you see the medical marijuana come in, is that the argument for this, I guess, is that they're no longer entering into an illegal interaction, so that they aren't encountering triggers, they're not doing something illegal, and possibly, I think, maybe it could help them with the recovery. But that was my question too, is have you have any anecdotal evidence about people tapering down off their...
For addictions? For a person that's addicted, I don't. I know this, but this is just personal story in the sense of when I started the State House and lobbying for cannabis dispensary, It was probably 7 or 8 years ago, and and in Berkeley they started to talk about, hey, addiction and cannabis. And I remember talking to people at the State House, and they're like, do not mention those two things. It's another drug. Don't do it. But over time, over the past 8 years, here we are. It's a conversation to be had, and that's why I'm bringing it up, because I just think it is an alternative potentially for some people, not everybody. But that currently the crisis is such as 52,000 people dying a year from this. Why not look at potential things that are here in Vermont that could help people? So.
I mean, anecdotally, we do.
There's a new study that came out just last month that showed that if you use marijuana, you're 3 times as likely to get hooked on an opioid. There's a lot of other research that backs that up. For example, there's a genetic phenomenon. If you have in animals, if you give 2 groups of female animals marijuana before they're before they even get pregnant, and then you follow their kids and their grandkids, and you control that against the genetically identical control group, then the ones whose grandmother was exposed to marijuana, they're a lot more likely to become an opiate addict when they're exposed to marijuana the very first time. And on top of that, in Colorado, they're finding that if you are born to a mom who has THC on board, or if you're a stillborn from that mom, or an abortion fetus from that mom, and you compare that to a mom who is THC negative, those brains have more opiate receptors. There's also the nucleus accumbens that changes. So there's a lot of
more study. I agree. There's this.
I think there's a lot of data that supports the idea that marijuana does increase both relapse. I personally know someone who relapsed and died, and this idea that it sets up your children and your grandchildren, not even knowing it, to be an epigenetic phenomenon. And I think that this story that's happening in the State House is extremely historic.
I appreciate that you're here to say that. So.
Reviewed that data carefully with the Department of Pharmacology and a bunch of medical professors here at the med school, and a lot of the studies with opioids, the idea that cannabis leads to opioid addiction were done in places like New Zealand, where people don't usually have access to drugs. So once you get access to any drug, you interact with drug dealers, and you can be more likely to be dependent. But that data doesn't pan out in the U.S. And I think it's really, you have to look at the effects of marijuana in the context of the opioid epidemic. It's certainly
And this is it.
All of the evidence that's been reviewed by medical professionals does not support that conjecture. It's definitely plausible.
So it's 7:30, and our time is up. I can tell people still have a lot of questions. But I'm going to sort of formally say we're going to wrap this up, and if you guys can hang for a couple more minutes.
Yep, happy to.
I really appreciate it. Thank
Yeah,
you guys.
thank you.